Hi, this is Eileen with Biga, and I'm out walking again. And the last time I did this, I was talking about self-limiting behaviors and how I hear a lot about that and what some of the reasons would be. And I thought, well, I want to itemize that a little bit better and give some ideas about how we can help them. All right, so I just kind of sat there and tried to think of some of the things that either are self-limiting for real or appear like self-limiting and made a little list. So I'll say what they are, and then I'll just give some ideas about what could help with it, if we can. So the first one I came up with was that the patient doesn't really care about what you're doing. So if you come in and they think that all you're offering them is to go down to the gym and do pegs or do weights or something, maybe they really don't care about that. Maybe they don't understand why we're having them do that or what that means, and they don't see any relevance to their lives. So I think the first thing that we should do, if that is the case, if we think about it deep and we go, okay, I think they just really don't get it, or you just ask them and say, well, why are you not into this? They could just say, well, it's stupid. I don't want it. Therapy's just stupid. So you can ask them what they think is stupid and get them involved. They should have a part in doing their goals, and they can make decisions and get invested about what they're going to do. If you go in their room and they don't want to do what we're asking them to do, go to the gym or whatever, say, okay, well, what do you need to do? And 98 at least percent of the time, there is something that they do want to do. Either they have to go to the bathroom, which is a big one, or they want to brush their teeth, or they want to sort out their purse, or they want to hang up their jacket, or they're hungry, or whatever. So if we can tap into what's important to them, they'll do it. On the thing about feeding, a lot of people get where they don't eat, and in a facility, they're only presented with food at meals. And if they don't eat the meal, or if the meal is too much at one time, they're just kind of screwed because they're going to be hungry. So in cases like that, feeding is a totally perfect thing to work on, because let's just face it, if they don't eat, they're not going to live, and all the therapy in the world doesn't mean a thing. So you got to think a little bit out of the box and just look at them. What do they need? What do they want? If we can get them invested, they won't limit. Okay, so that's one of the things. Get them invested in what we're doing. Two, I think a lot of times people appear self-limiting or don't want to do things because they're scared. They're fearful. A lot of times they're afraid they're going to fall, especially if they work with somebody who's on the smaller side like me, or a girl, a woman. They're very afraid of falling because a lot of times they've had that experience where an aide or another person didn't have them and they were going to fall, so now they're just afraid to do it altogether. A lot of times they just don't want to look stupid. If they have some cognitive things going on, they're afraid they're going to be embarrassed because they look stupid in front of you. They're afraid that we don't understand their limitations and we're going to push them too hard. A lot of times they're like, no, 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 I can't do that. I can't do that. And they don't trust us to not do more than they can do, that they're getting in over their head. And I think the best thing to do about that, of course, is to reassure them. You have to go super slow, a little at a time. I tell them all the time, we're just going to try this. Here's what's going to happen. We're going to try and stand up. And if you can't stand up, then we're just going to sit back on the bed. You're not going to fall with me. And you just go super, super slow. And a lot of times, when they feel like they have control, they'll do a lot more. That's a big part of that. Them feeling like they have a little control over the situation and that you're going to listen to them. Or if something hurts, maybe they have pain and they're afraid that you're going to just go in there and be cranking on their hand or something. And so they don't want any part of that because they don't trust you, that when you're opening it to hear, that you're just not going to go, whoa, and just go to town no matter what they say. And I'll have to say, a lot of times in therapy, I have seen therapists do exactly that. When the patient finally gives them their hand, they're like, oh, no, no, and then they just crank away. Well, that might be getting your range of motion that you want for that day, but you can be pretty darn sure that the next time they see you coming or anybody coming, they're not going to let anybody touch that hand. So on the fear, going slow, reassuring, having some humor, acknowledging their fear, that can go a long way to get them to participate and try new things that they're afraid. Because once they trust you, then they'll trust you and then they'll do it. The other thing, which is I think pretty closely related to that, but a little different, is that they have no confidence in themselves. They're depressed. I've had so many people say, I'm just done. I can't do that anymore. Like they look at themselves like they're no good and they can't do these things, and things are hopeless. They're old. They're knocking at death's door. There's just no point for them to do anything, and it's just depression. And I would say, I think I said in the last one, depression is just rampant. And in the facility they try to give them drugs, but what's a drug going to do if you don't change your situation? So they just look at themselves as a useless pile of nothing, and so why bother? And I think the best approach that we can have on that is to understand that and say, I know you feel like this. I have a lot of people feel like that. Reassure them, validate them. I do talk about depression with them. I tell them how common it is and how it makes sense, and most people feel like that. But between here and the last day, you're still living, and let's have a little fun just for this day. And I think humor and the use of yourself goes very far. And in a case like that, I wouldn't even worry about the gym. You just want to get them invested in life in general. You want them to think, wow, she's a cool person, and I would enjoy hanging out with her. And once you do that, then you can sneak in the little therapy things. Maybe they're only going to sit on the bed. You can go get their pictures. That's trunk work, all this stuff. Laugh, go, oh, I had a lady one time, and she had been a baker. And so her family had made her a photo album of cakes. So she didn't want to do nothing with me. She was depressed, done, nothing. I can't do that no more. I said, well, all right, how about if you just sit on the side of the bed here with me and we'll look at these cakes? That kind of popped her right up, And it didn't take long before she had to go to the bathroom. So I think understanding and, again, going slow. Don't be, I would say, we can't beat the therapy horse. We just go where they are and consider it a win if they engage with us. One of the things I like to do is, when they really are not into any of it, is say, okay, let's talk about your family. And especially when they have a lot of kids, I have them list off all the kids. And then if they're married, who they're married to. It's a cognitive activity. And I find it fascinating and much better than Claudia Allen to see which kids they remember, who they don't remember. Do they get all the kids but not the grandkids? And they usually really enjoy it too, because either they'll get them right away and they're proud, and then we can talk about the kids and we can go into further things like what year they were born and everything, or it's kind of a little wake-up call like, wow, I forgot, which makes them want to work their brain at least, because nobody wants to forget their kids. And a lot of times once you do this kind of fun thing, well, then it's not a really big jump to sit on the side of the bed, to get in the wheelchair, let's go get a drink of water out in the kitchen, let's stand and walk to the bathroom. And a lot of times you kind of cut through it a little bit, at least for then, and you'll certainly be building up good rapport for the next time. So the third one was no confidence, the depression, and just a couple things on how to get through some of that. The fourth thing I came up with why they don't participate or they are self-limiting and not doing it is dementia, and they forget. In that case, it's really not self-limiting, really, because they just don't get it. They can't remember, they can't follow through, they don't really get what's going on or why they're there. And in that case, the whole thing you can do is we have to just change our plan. We have to change our plan of attack. At that point, we realize they're probably not going to be safe by themselves. So to me, I think repetition becomes the key. We get up, get down. I do this thing with almost all of them that I call ups and downs. And what it is, you get up out of the wheelchair, you walk over to that chair, and you sit in that chair. Then we get up out of there, and then you go over there and you sit on the bed. We get up out of there, and you go on the toilet. And the reason I like those so much is because when people go home, or they're with their family, or even in the nursing home, they don't just sit there and boom, fall out. Usually, not that never happens, but they go down when they're trying to get from one surface to another. They're going, oh, I want to go sit in the recliner, and they just don't have it. So I do all of that a million times over and get them to remember. It's a very good problem-solving activity because it sounds like there's not a lot of thought to it. And for you and me, maybe there's not. But for a lot of those folks that are in the facility and everyone's like, do this, do that, the aides usually just go in and there's no finesse about it. They just grab them under the armpits and haul them over. They forget how to stand up and get into another chair. So that's not so much a self-limiting as they just can't do it. So that's up to us then to change our plan of attack. All right, the last one that I came up with about self-limiting behaviors is when they truly are self-limiting behaviors because a person is attached to their disability. And it's not a politically correct thing to say, but plenty of people have a real affection for their disability. All kinds of reasons. Maybe it makes them the star of the family. People cater to them. Maybe it's a way that they get money. Maybe it's a way that they don't have to fulfill roles that other people have to fulfill. It's maybe a way out of work. There's a whole lot of reasons why people don't want to get too much better. Maybe it's a way to get drugs. And when that happens, the worst thing to do is give too much encouragement. Oh, no, you did great. You did great. That was really good. That's the worst thing they want to hear. And if that's the situation, you're probably not going to win because the other forces out there that are impacting on them, the gain that they're getting from having the disability is so much bigger than you can ever give them by getting rid of the disability. And in that case, you just sort of have to accept it is what it is, do the best you can, and move on. So, all right, so I came up with 5 reasons for self-limiting behavior, what appears to be self-limiting behavior. The first one was they are not really invested and don't care about what you're doing, in which case we have to change goals and get them invested in making the plan. The second one is that they're afraid, which involves a whole bunch of reassurance, going slow and giving them control. The third one was no confidence in themselves, depression, thinking they're done, which is the best way is to be understanding and address where they are, take a step out of the world of therapy and just see if you can get them to invest a little bit just in living. The fourth thing was dementia and forgetfulness, which isn't self-limiting. That's on us, and we need to get a totally new plan. The fifth one is true self-limiting, and they're just attached to their disability, and you know what? It's their life. So what can you do? And all of the little hints I came up with about this, none of them can be done looking at a computer. This is why I hate point of service so much, because in order to impact people and help them get up out of these funks that they're in and these self-limiting whatever, is you have to look them in the face. You have to feel out where they are. You have to, or we have to, I don't mean to be sounding like that, we have to reach out to them. It's in therapy with elders, it's not like you got 2 people and they're even and they each are playing their role and then they meet in the middle. They can't hold up their end a lot of times because of their depression, because of their pain, because of their dementia and their forgetfulness, whatever is the thing. They cannot come 50-50 to you. So when you say, okay, sit here and kick your legs and then we're going to do these things, they can't do it.